really excellent presentations by each of you. Thank you. So before I take a chance to sort through the file cards that I have, I just want to make a couple quick comments. I mean, you know the world is changing when you have to change the rules to make sure that you know that the world is changing. So, and that's not been easy. I'll turn to you first, Dr. Wolchok. The FDA often gets a black eye for not doing things the way people expect them to do so. However, in the case of oncology, I have to say the Food and Drug Administration group led by Dr. Rick Pazder has really done a lot to advance the field. And yet there still is some work that needs to be done, especially in this area of endpoints. Can you talk a little bit about the current conversation around endpoints and really what are some of the challenges, and sort of put yourself in the shoes of the FDA so folks here can understand some of the complicated nature of that?
Yeah, thanks, Louise. It is a complicated situation. We all want new medicines approved very quickly, especially when they're showing signs of activity. I think that there are really recent indications that the FDA has a very open mind about this. And I think the fact that we saw pembrolizumab approved based upon phase 1 clinical trial data is very strong evidence that the FDA is trying as hard as possible to be flexible about this. I personally don't really recall many instances where a medicine was approved based upon phase 1 data. I think some of us really might have questions about whether or not patients needed to have BRAF inhibitors or exposure to ipilimumab beforehand. So yes, there's still room for discussion about how that data is interpreted when approvals are made. But to be able to bring medicines like that into the standard therapy space based upon non-randomized data it's a very important signal to the community that the FDA is trying. Now, endpoints are trickier because, as I showed you, response rates, which have been challenging for ipilimumab, not so challenging for the PD-1 blocking medicines, but response rates don't really accurately capture the activity of ipilimumab, for example. It's really the survival, but we can see that it took many years for that survival data to mature to the point that the drug could be approved. Now there are surrogate endpoints such as landmark survival or percentages of survival at different points in time that might be adequate surrogates for overall survival. And in fact, the Cancer Immunotherapy Consortium about a month ago in New York had a workshop to discuss this as well. So I think that there's a lot of dialogue that's going on between our industry colleagues, our regulatory agency colleagues, and ourselves to try to come up with the most really effective and efficient ways to bring medicines out of clinical trials and into standard use as soon as possible.
Thank you. I'll start with you, Dr. Paul, on this one. Is there a correlation between the bulk of disease and the response to immunotherapy? I have to say I was struck. I hadn't realized that 7 centimeters was kind of considered okay. That's sure. Big.
Yeah.
But is there any relationship between bulk of disease and immunotherapeutic response, to the best of your knowledge?
Sure. It's a great question, and I will just point out that size actually pertains to stage of localized disease. Principally what we're seeing, of course, in the medical oncology clinics is metastatic disease. In that context, and I think we have delved into this issue in the context of bladder and kidney cancer, I personally haven't noted any correlations between tumor size and extent, although certainly I think there are plausible mechanisms to suggest that may play a role in response.
I think this is an issue that needs to be explored more, but I think it's been pretty clear from the melanoma trials that the more cancer that's there, the less well any of the treatments work. So is that a specific issue to immunotherapy? I'm not so sure. There may be, as the tumor grows, there are all these inhibitory factors, and if there's more there, that may dull the response to some degree. For a long time, I think for IL-2, that was out there. It was thought that a lower volume of disease was more likely to suggest that a response could be possible. I think in the current era with immune checkpoint blockade, there isn't really an alternative. So it's a hard comparison to make. I would still treat a patient no matter how much disease could be there.
I think that's important, that these are not binary distinctions, that there may be relative changes in likelihood of response based upon the numerical amount of disease, but it's not as if people don't respond, it just may be less likely to respond. And I also think that, and actually it was Dr. Hody who had a talk at ASCO about pembrolizumab and extent of disease, and it was true that patients who had more disease, more bulky disease, were less likely to respond, but it's not zero. And I think that some of that is biased a little bit because of how advanced the disease may be in patients who have a high bulk, and maybe, unfortunately, they're getting too sick too quickly for the immunotherapy to catch up. So I think, yes, catching things earlier is better, but it's not a yes or no. It's more shades of gray.
And this may suggest also where these combination approaches or sequences of other drugs could have a role. So we have these other targeted therapies that can work very quickly, and if there is an issue about bulk of disease, perhaps you could shrink it and then transition to immunotherapy.
Yeah, I wanted to follow up on that. And is that a hypothesis as well in kidney cancer, that shrinking the disease using targeted therapy first may be advantageous?
It's something that I think can be easily examined in the context of the one registration trial right now that's ongoing in renal cell. The study recently completed accrual. We're waiting for results. This will randomize patients who have received 1 to 2 prior therapies to everolimus, which is an mTOR inhibitor, or to nivolumab therapy. So that's certainly a setting which we can explore the extent of prior therapy and its relationship to the effect of a PD-1 inhibitor.
Mm-hmm. Coming back to the topic of biomarkers for a moment, obviously there's a lot of conversation around PD-L1, very important hypothesis to test, and some of the data suggests that it's complex, not least of which because PD-L1 is expressed not only on the tumor cells but on other cells as well, and it's mutable as time goes on. But what are some of the other hypothetical biomarkers? I think you mentioned absolute lymphocyte count. Are there others that come to mind?
I think it's still very early to start talking about especially predictive biomarkers that are present at baseline. I think there are some biomarkers that we can use once someone has started treatment, the rise in the lymphocyte count or the infiltration with immune cells. But I think right now it's really too early to make any decisions based upon biomarkers. One area which I know was spoken about earlier today was also the mutational burden of individual tumors. How many genetic changes are present, and the tumor may be an indicator of how likely it is for immunotherapy to have a beneficial effect. But I think that all of these biomarker discussions need to be interpreted in the context of them not being static or binary. I think for the melanoma patients in the room, this is not like BRAF mutation. For the lung cancer patients, it's not like an ALK translocation. There is nothing that is involved in the melanoma, in the genetic program of the tumor cell that is determining the likelihood of the response of immunotherapy that we can detect at baseline. Maybe there will be something that we will find, but right now I think this should be considered a reasonable option for anybody without a biomarker.
I was just down the street at the Kidney Cancer Association meeting, which was conducted over the past 2 days. And Ari Hakimi and some of your urologists over at Memorial have done some nice work using kidney tumor specimens to suggest that as opposed to PD-L1 predicting outcome, there may be a surrogate that's comprised of several biomarkers, Tregs, MDSCs, et cetera, that may potentially be more useful.
Mm-hmm.
So at the University of Chicago, we've been looking at whether or not a gene expression profile that suggests what genes are on and off in the microenvironment might express. But again, it's so early that that's not something you can ask your doctor about to say, is this
right.
thing here? The other thing I just wanted to double down on is that the PD-L1 test that's done by the different companies is a different test for each company. So when you do sequencing of the tumor, you may find that the BRAF mutation is there or not. If you do a different company's mutation test, you should get the same result. That's not necessarily the case for PD-L1. They're testing different things. Sometimes they're testing the immune cells, sometimes the tumor cells, sometimes the blood vessels, and so it's not across the board.
I just think that there's been an appropriate rush to know PD-L1 status of individual tumors because it seems so logical, but like many things in science and medicine, it ain't so logical. And it's way more complicated than imagined. So I think right now, this should not yet be used to make any decisions.
Yeah, it's sometimes difficult for folks to appreciate, if you're not a scientist, that it's not really black or white, and how you actually do something makes a difference. But it's like the difference between a Betty Crocker cake and pick your other favorite kind of cake. They're going to come out slightly differently depending on what kit you use, and this is the case in these circumstances as well. Talking a little bit about pseudoprogression, or the situation in which some lesions are progressing and others are regressing, is there a way to quantify the symptomology that somebody actually feels better? Is there a way to actually quantify that versus someone being aggressive and New Yorkish and in your face, that we can harness that to help patients know whether they should be concerned or not?
So yeah, I mean, there are at least 2, perhaps 3 or 4 different numerical scales called performance status scales. Everyone has their favorite at Memorial. We use the Karnofsky, which is because Dr. Karnofsky worked at Memorial. But I think that these are just numerical scales that measure how much a person can do each day. And it just tries to put a number on level of activity and compared to fully healthy baseline. But I actually think that if someone tells you they feel better, that's meaningful. You don't necessarily need a number.
I would just second that. I think that this really emphasizes the communication with your physician and having an open conversation about how you're doing and whether or not you really are better or whether or not you're not, and helping to guide whether or not you can wait.
Okay. And speaking of conversations with physicians, at this point in time in melanoma, I was going to say it seems clear what conversations patients should be having, but maybe it's actually not so clear. Can you, how does that work in the office? Do patients come in and say, this is what I want to be treated with? And you say, okay, maybe I can, maybe I can't.
Some come in and say that.
What should they be saying?
I think it's different from person to person. There isn't one right answer. I think people have personalities that got formed way before cancer was diagnosed. And I think our job as caregivers is to try to shape our recommendations around the way that people are used to giving and receiving information.
We had a really interesting discussion in the renal cell section pertaining to where clinical trials are principally being offered within the disease state. And what we're seeing more and more is that trials of PD-1 and PD-L1 inhibitors are being offered to treatment-naive patients in the first-line setting. And that's oftentimes a challenge at a tertiary care center. At City of Hope, for instance, I'll oftentimes see a patient after they failed on 4 to 5 prior therapies, and it's frustrating not to be able to offer them PD-1 or PD-L1 inhibition as a strategy. So as much as possible, and maybe we could harness some of the strengths of the group of folks in this room, we need to get word out there that there are many first-line trials ongoing for the disease. And
coming to the subject of different approaches one might take to contribute to clinical trials, specifically pre-surgical approaches or adjuvant approaches, is there any concern in your mind about a neoadjuvant treatment with an immunotherapy, or do we not know at this point, Jason?
I think we don't have enough information. I would advocate that clinical trial participation is essential, and if it is a reasonable thing that you can participate in, I would advocate for it, but I don't think we really know the answer yet. I put on a bunch of hypotheticals on the screen there, and I think that unfortunately that really is the state of our understanding. We need to learn more, and the only way we're going to do that is through clinical trials.
That's actually how we arrived at today when we have effective immunotherapies, is through clinical trials. And fortunately, the kinds of clinical trials that gave clinical trials a bad name of placebo-controlled randomized trials, those are becoming more and more scarce. And I think now we're seeing more creative trial designs, such as the ones that Dr. Luke just mentioned, these neoadjuvant trials where everybody gets the medicine and you just have a surgery procedure a few weeks later. But I think that's an opportunity to consider receiving a very experimental approach. and having a lot of scientific information gained. So I think clinical trials are very important. They're not right for everybody. As I tell all my patients, we're not in the arm twisting business. Right. So for some people, they are the right answer, and they are a definite option in every discussion that we have. But I think for some people, they're right, and other people just feel that they don't want to participate. And fortunately now, we're able to offer some of these medicines in the standard therapy setting.
A couple last questions. Can patients who have had transplants benefit from immunotherapy? And a bit related to that, given the relatively long experience of immunosuppressive therapy around transplantation, are there lessons learned from that that have informed our current understanding?
So I think those clinical trials are ongoing to look at the role of immune checkpoint blockade drugs after transplant. I guess I'm biased, so I think probably it's likely that they will help. There are a number of different approaches that are being looked at. In terms of the immunosuppression issue, that's actually been part of sort of standard melanoma practice actually for a long time. Melanomas sometimes develop in the setting of immunosuppression, and so whenever we see that, the first thing we try to do is lessen the immunosuppression, and we see sometimes that just doing that in and of itself makes the melanoma go away, and we don't actually need to administer any drugs at all. So, in the context of these drugs, the answer is try to get down as much as possible. It is the case, though, sometimes it's necessary, and that just has to be incorporated into the treatment plan.
And how about in the kidney arena? I mean, kidney transplants are relatively common. Is there an increased predilection towards cancer? Anything to be learned there?
Sure. So I will say that in the context of kidney cancer that arises after a kidney transplant, most trials that are ongoing right now will exclude patients that are on a substantial amount of immunosuppression, but certainly down the line it's something to explore.
Okay, great. I want to give you the opportunity of the last words before I turn it back over to Jack. Last words for patients when they embark on their journey and are considering an immunotherapeutic?
I think from my perspective, it's that feel comfortable to advocate for yourself. Tell the doctor how you feel and feel confident it's okay to tell them. They're supposed to listen. And so it doesn't have to be all about clinical trials and all of this, but they should listen, you should be able to tell them, and you should have a good relationship.
Yeah, I may propose that there are resources out there. I completely agree with your comments, but there are web-based resources that I do trust, Cancer Grace being one of them, and Dr. West has done a great job in leading that over the past several years. Utilize those to the greatest extent possible in clinical decision-making.
Yeah, I would echo all that and just say that if you don't understand something, it's okay to say that to the doctor or the nurse or the nurse practitioner or the PA. It's very important that when you go on a new treatment, like many of these immunotherapies are, that you understand what they're doing and that you understand what the side effects are. Often we all are in a great hurry to get through all the paperwork and what have you that's required to start a clinical trial with some of these new medicines, and I often have to ask my patients to slow down and actually read the forms before they sign, because they say, oh, it says PD-1, I'm going to sign, right? But no, I think it's important because the more you understand it, the more you'll be in tune with what the early side effects are so that we can intervene at a very safe point in time.
Great. Thank you all very much.